Hello, ladies and gentlemen. I will give a talk on the impact of abdominal hypertension on hemodynamics. These are my disclosures. I'm a member of the advisory board of Göttingen, biggest bias being the co-founder of the World Society Abdominal Compartment Syndrome, now named the Abdominal Compartment Society. I'm very fortunate to have met Mathilde, Queen of the Belgians, and King Philip during the last or the first wave of the COVID pandemic, as well as Maggie, former Belgian Minister of Healthcare. We'll give an introduction and then tell you about the impact on cardiodynamics and introduce CARS. Why do you need to know this? Well, maybe you don't. Maybe you like it because it's something new. I don't know everything either, but it will change your clinical practice. If I would ask you who measures abdominal pressure, I think around 25-30% would do so. We've all seen patients with abdominal sepsis or COVID who have a high body mass index, fluid overloaded, get a distended abdomen, then have AKI, end up CVVH, and then may do a cardiac arrest and have a necrotic bowel. But the question is, did you measure abdominal pressure in those patients? Performing a PubMed search, you see an exponential increase of studies published, and our first consensus definitions papers has been the most cited article from intensive care for a long time. It was revised in 2013, and we're working on a second revision. This is a landmark, it's the Eiffel Tower in Paris. This is another landmark, it's the Atomium building in Brussels, and these are two landmark papers on the incidence and prognosis. Bottom line is that the higher the abdominal pressure, the higher the mortality. And the Kaplan-Meier curves were nicely separated with a cutoff of 12 millimeters of mercury. We also performed a meta-analysis, and abdominal hypertension was an independent predictor of survival. So 1 in 4 have hypertension on admission, another 25% during the first week. 1 in 20 will have a compartment syndrome with high mortality, and you wouldn't know it unless you measure abdominal pressure. And it's also the case in COVID-19 patients. If you look at the abdomen, gravity, uniformity of compression, shear stress, and contractions of the abdominal muscles will determine how a certain intra-abdominal volume will have resulting intra-abdominal pressure. When the pressure increases in the abdomen, this will result in an increase of the pressure in the thorax and also in the cranium. On average, this transmission is around 50%. If you would look at the abdomen cross-sectionally, it would normally be ellipse-shaped. When you increase the volume, there is a reshaping, stretching, and then a pressurization going to the circle. Abdominal compliance is the change in volume over the change in pressure in the abdomen. And maybe this is a neglected factor in organ-organ interactions. We recently published a lot of reviews on this topic, and you can have a look at them as they are open access. When we're giving fluids, there will be fluid accumulation. Bowel edema, ileus, and abdominal pressure will increase. There will be compression of the vena cava, reduced blood flow to the heart, reducing cardiac output, and hence reduced flow to the organs, and this will incite a vicious cycle of multi-system organ failure. As an internist, I got fascinated in the abdomen because increased pressures in the abdomen have a dramatic impact on organ function within, but also outside the abdominal cavity. And this is the list of cardiovascular effects, and we will go a little bit into detail. The effects on preload, afterload, contractility, and functional hemodynamics. What about preload and the CVP use in abdominal hypertension? If you look at the impact of abdominal hypertension, going from 0 to 5, for instance, you see an increase in venous return. But the higher the abdominal pressure, then venous return will drop. Intra-abdominal hypertension on the right increases CVP by an increase in pleural pressure. And this has been old data in dogs in the 80s and 90s. So CVP is only a small part of venous return. So first lesson, it is not a good parameter of venous return, especially not in patients with abdominal hypertension. Better alternative is mean systemic filling pressure. If you look at other data, you can see that abdominal hypertension increases CVP and wedge pressure, because we assume preload for the left ventricle equals a pressure measured in the right. And there are a lot of assumptions, one being whether intrathoracic or intra-abdominal pressures are not elevated. CVP is not a good static preload parameter, so better alternative is volumetric preload. Chasing a static CVP target from 8 to 12, like initially suggested by surviving sepsis, is not a good idea, as this may lead to under or over resuscitation. This is a classic figure of what happens with baro and volu indicators of preload during increased intra-abdominal hypertension, and the CVP indicated by this motorcycle driver going in the wrong direction is useless. We performed animal study in pigs where we increased abdominal pressure with infusion of saline, and you see an increase in CVP and wedge, but not in the transmural CVP and wedge. They may rather decrease. So can we make the CVP better? If you look at changes of CVP or changes in abdominal pressure, you will see on average the transmission from the abdomen to the thorax is around 50%. So transmural CVP is better, lesson 4. If you look at volumetric indicators, you see in these different studies that abdominal hypertension decreases global endostolic volume. And in this ultrasound study, looking at left ventricular endostolic area with increasing abdominal pressure, there is a drop in this volumetric preload parameter. The old animal data from the 80s show that when abdominal pressure increases, Frank-Starling curve goes to the right and flattens. Abdominal hypertension decreases left ventricular contractility, also shown in this study with TEE in children where the anteroseptal regions showed a contractility. Because I want to know what is Frank-Starling and where is my patient on the curve, we have different forms of ejection fraction from the right ventricle to the left ventricle, and global ejection fraction should be above 35%. You will agree when ejection fraction is better, the resting endostolic volume will be lower. Hence, it makes sense to correlate ejection fraction with the target endostolic volume. And this is what you should do, especially in abdominal hypertension. This is a pig study we performed with Gregorio Castellanos from Spain. It was a fluid-filled model of abdominal hypertension in the bowel, and you can see that the aorta, when it enters the abdominal cavity, is compressed. So lesson 8, intra-abdominal hypertension increases afterload. Effect on pulse pressure variation. This is again caused by an increase in intrathoracic pressure, and you can see in these pigs that PPV increases basically due to a delta up phenomenon. Another study by Didier Jacques, you can see the same abdominal hypertension increases PPV, and the threshold for fluid responsiveness is changed to values above 40%. So I'm not sure how this relates to clinical practice, where we usually have a cutoff of 12%. Bottom line of these animal data is that if you double abdominal pressure from 10 to 20 millimeters of mercury, this also doubles the SVV and PPV values. In France, they have active flag raising, but also passive flag raising. In this study, where all fluid responses were compared, and there were some who had a negative passive flag raising, but those had an increased intra-abdominal pressure of 16. Because in normal condition, with a passive flag raise, you will have an autotransfusion from the legs and mesenteric veins, whereas in abdominal hypertension, because of this back pressure in the abdomen, venous return will not come to the central circulation, and you can have a false negative passive flag raising. Lesson 10, intra-abdominal hypertension may have an impact on the passive flag raise, and in those situations may be better to perform a Trendelenburg position, taking into account the limits of the passive flag raise maneuver. This is a very nice slide by Xavier Monet, summarizing the impact of abdominal hypertension on inferior vena cava compression, diaphragm elevation with a problem, left ventricular afterload, compression of the aorta, left ventricle afterload increase, all resulting in a drop in cardiac output, drop in blood pressure and abdominal perfusion pressure. And the increase in intrathoracic pressure will have an impact on functional hemodynamics, false negative passive flag raise, where the end expiratory occlusion test and the minifluid challenge test could be used in abdominal hypertension. If I would ask who does not believe in abdominal hypertension, have a look at this video of a burn patient who is hypothermic, received a lot of fluids, has ventilated tidal volumes around 100-130 ml, peak pressures of 55 centimeters of water, and then sudden cardiovascular collapse. So this is what happened: severe burns, abdominal distension, high peak pressure, so low chest wall compliance. Abdominal hypertension can be fatal. One more thing, if you look at heart-kidney interactions with a low cardiac output, there will be forward failure, but there is also an increase in CVP, venous congestion, increase in abdominal pressure and renal venous pressure. So you have backward failure in combination with the forward failure, and the abdominal pressure is usually the canary in the coal mine for development of AKI. When abdominal pressure is increased, this will result in an increase in central venous pressure, portal vein pressure, and renal vein pressure. So we may talk about CARS, HAPS, and HARS. And this refers to the polycompartment syndrome. The term cardioabdominal renal syndrome was coined a couple of years ago, focusing on the important role of abdominal pressure in understanding worsening renal function in patients with congestive heart failure, and abdominal pressure may just be the missing link. So to wrap things up, at least in my practice, intra-abdominal pressure is very important at the bedside of clinically ill patients. Think about the polycompartment syndrome, think about transmural filling pressure, volumetric ones, the impact on pulse pressure variation, impact, of course, on GI tract. It may be the missing link in understanding AKI. We need to adapt our enteral nutrition. It has an impact on liver function, the way we ventilate, so we need higher opening pressure and higher PEEP, and has also endocrine function. So I would like you to go home with the following messages. Think about the polycompartment syndrome, and changes in abdominal pressure may have an impact on changes in filling pressures. Think about cardioabdominal renal syndrome. Use volumetric instead of barometric preload. Endostolic volume index, maybe use the ejection fraction corrected values. Calculate the abdominal thoracic index of transmission, and you can estimate transmural filling pressure with the rule of thumb by subtracting half of the abdominal pressure from the end-expiratory CVP. Get the right fluids right, so not too much, not too little. Resuscitate towards abdominal perfusion pressure in analogy to cerebral perfusion pressure. Be cautious with the functional hemodynamic parameters. So best is to use PPV. Remember that passive lactate can be false negative, and the thresholds for PPV need to be adapted maybe from 12% to 20% to define fluid responsiveness. On the website, you can find a treatment algorithm. If you want to know more about abdominal pressure, this is a very good book by Cambridge University Press. There will be a soon book out on compartment syndromes, and there is an open access clinician's guide to the management. Having said that, I invite you to join the Fluid Academy, where you can have open access educational material. I thank